Nauman, Assistant Professor from Dow Institute of Radiology, OCHA campus. Today we'll be talking about neuroradiology of stroke, cerebral angiography, and interventional radiology. Before starting, we should recite dua. Bismillahirrahmanirrahim. Rabbi zidni ilma. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. So, what is a stroke? Stroke is an acute episode of neurological defect. What are the common causes? Cerebral infarction, which is almost in 80% cases. Intracerebral hemorrhage, which accounts for 15%, and non-traumatic subarachnoid hemorrhage, which accounts for 5%. What imaging modalities we employ to investigate it, which are CT scan and CT angiography, MRI and MR angiography, conventional angiography, and Doppler ultrasound of carotid and vertebral arteries. Now, which initial investigation we should do in stroke? We should always go for plain CT scan brain. Why? To exclude intracranial hemorrhage. So, patient can be started on anticoagulant therapy. To exclude any underlying mass lesion or any arteriovenous malformation. Secondly, it is easily available as compared to MRI. Okay. We should be aware in different populations what are the common causes. In pediatric population, congenital heart diseases is the topmost cause. Other causes are blood discaresis, meningitis, arterial dissection, trauma, ECMO, venous thrombosis. In young adults, cardiac emboli. Other causes are atherosclerosis, tracheostomy, arterial dissection, coagulopathy, vasculitis, venous thrombosis. In elderly population, atherosclerosis is the topmost cause, then cardiac emboli, coagulopathy, amyloid, vasculitis, and venous thrombosis are the rest causes. Okay. Now, what are the stages and radiological appearances? Stroke is classified as hyperacute, less than 24 hours, acute, less than 1 week, subacute, less than 1 month, chronic, more than 1 month. This is a shortcut to remember. Now, on CT, less than 6 hours, it is difficult to recognize. So, it is termed as isodense. Then, with time, the density decreases. So, it is termed as hypodense. So, how can I differentiate between acute, subacute, and chronic stages? There comes other radiological findings. Either there will be mass effect, or there will be resolution of the mass effect, or there will be the retraction. On MRI, in hyperacute, it is iso-intense in less than 6 hours. On T1 sequence, there are two most common sequences, T1, T2, basic concepts, if you are aware. T1, fat is bright, T2, CSF is bright. So on T1, T2, it is iso-intense. It means it is equivalent to the density of intensity of the brain parenchyma. It is difficult to figure it out. But with time, it becomes hypo-intense on T1 and hyper-intense on T2. Then there comes the role of other sequences. Okay. So these are the signs which you need to be aware of. On CT scan, loss of gray white matter interface, effacement of sulci, definitely this comes with the mass effect, and dense artery sign, like dense MCA sign on CT, likely due to the thrombus inside. Then other features which I have told you: edema, maximum at 3 to 5 days after infarct, reperfusion hemorrhage, mass effect, and atrophic changes, especially in chronic infarction. This This is the CT scan brain plain axial section. Okay. Why am I saying plain? Because no contrast has been given. So whatever it is, whatever bright is either calcification or blood. So here comes the role of our knowledge of anatomy. Radiology is nothing but anatomy. God has given us two equal sides to compare. So if we are aware that these are the level of the basal systems, and this is the level of the MCA, and this is the normal middle cerebral artery, which is not that much hyperdense, but this we can see that this one is hyperdense, and this is signifying the hyperdense artery sign, which is the thrombus in the right MCA. Okay, now another sign which I have told you, that there is loss of gray-white matter differentiation. Look at the left cerebral hemisphere. There is good gray-white matter differentiation. We can easily see the cortical, the sulci and the gyri. But look at on the right side that there is loss of gray-white matter differentiation. It is all lost, and there is diffuse hypodensity. So this is signifying the effacement of sulci, loss of gray-white matter differentiation, signifying acute infarct. Another, which I have told you about the mass effect. So this is causing partial effacement of ipsilateral lateral ventricle. Okay, this is non-contrast axial CT showing a dense MCA in a patient with a left MCA infarct. In the previous slide, I have showed you on the right side. Now I'm showing you on the left side. Further, you can easily see what? The low attenuation of the acute infarct in left frontal and temporal lobes. Again, you can see when I'm using the word acute, you can easily see the mass effect. Now, I have told you how you can differentiate. Both are hypodense. How you can differentiate it is acute or chronic, either with the history, but most of the time, if we lack the history, we go with the radiological findings. In the previous slide, you can easily see that there is a mass effect. But in this slide, you can see that ipsilateral frontal horn of the lateral ventricle is retracted towards the abnormality. It is pulling it. It means that there is volume loss. So it means that something is chronic. So this is chronic infarct in the territory of ACA. Here comes the knowledge of anatomy. Okay, this is MRI. I have told you on T2, the CSF is bright. On T1, the fat is bright. Here, I have told you the infarct is hypo-intense on T1 and hyper-intense on T2. And this is in the territory of middle cerebral artery. It is a sparing part of the frontal cortex. It is involving the parietal cortex. Okay. And which kind of infarct it is? It is acute or chronic? This is chronic because it is retracting the ipsilateral body of the lateral ventricle. Now we are well aware how the stroke appears on CT and MRI in different stages. Now the other part, the other cause, intracranial hemorrhage. Types of presentations. It could be intraparenchymal or intracerebral. It could be subarachnoid, subdural, or epidural. Now, what are the causes? Hypertension, trauma, aneurysm rupture, AV malformation, bleeding disorders, excessive anticoagulation therapy, and vasculitis. Okay. This is the knowledge of physiology and anatomy, that if the patient is anemic, it might not give that bright look on CT. If he has normal hemoglobin concentration, then the blood appears dense on the CT scan. So Hemorrhage appears hyperdense than the brain parenchyma on CT. Density of hematoma decreases from peripheral to center as the time passes. Finally, the hemorrhage becomes hypodense and atrophy of brain occurs at that particular site and side. No. Now, appearance of hemorrhage on MRI. There are again stages: hyperacute within hours, acute 1 to 2 days, subacute less than 7 days, late subacute up to 1 month, and chronic more than 1 month. Now, depending on the biochemistry, the appearances differs on T1 and T2 sequences. Now, this is the CT scan axial section plane. You can easily appreciate some hyperdensity in the posterior fossa, centered in the region of the pons and the left cerebellum. This hyperdensity is hemorrhage. Now, here you can again appreciate hyperdensity in the basal cisterns. Look, there is this globular hyperdensity along the left peripheral sign region. So it could be due to a leaking aneurysm. Now here comes the knowledge of our anatomy. What normal arterial distribution is here? Either it could be a rupture aneurysm from the ACA or anterior communicating artery. So it turns out to be a leaking aneurysm from left ACA. Now, on plain CT scan, brain axial section, we see a few calcific foci in the left middle cranial fossa, adjacent to the basal cistern, with another hyperdensity adjacent to it. On post-contrast, it opacifies. It means this is something vascular. It is an aneurysm. Now here comes the knowledge of our anatomy. What normal vascular structure is present here? Normal vascular structure is middle cerebral artery. So this is the aneurysm of left middle cerebral artery. Okay. This is the plain CT scan at the level of the bilateral lateral ventricles. Here we can see bright structure, a bright spot in the region of the right thalamus. Now on T1 and T2, these are the different stages. It is bright on T1. So on T1, whatever bright is either blood or hematoma. So this is blood. Now, the other okay. Now, after discussing the radiological appearances, we come to our next topic, that is cerebral angiography. Common methods of performing cerebral angiography are MR angiography, CT angiography, conventional angiography. How conventional angiography? Intravenous digital subtraction angiography and direct intra-arterial angiography. Okay. Here, again, the revision of basic anatomy, what supplies the brain, what is the normal cerebral vascular anatomy. It is supplied by internal carotid and two internal carotid, two vertebral arteries, making the famous circle of Willis, supplying the anterior and posterior cerebral circulations. How it looks on cerebral angiography performed after injection through vertebral artery. These are the right vertebral artery, left vertebral artery, uniting, forming basilar artery, dividing into right and left posterior cerebral artery, which gives, this is the posterior cerebral circulation. And what is the anterior circulation made of? By two internal carotid artery, dividing into middle and anterior cerebral arteries, I'm showing it to you. Okay, this is the contrast enhanced MRI of aortic arch and its branches. You can see from the aortic arch, the right innominate dividing into common carotid and subclavian, left common carotid and left subclavian, and traveling in the neck. Okay. This is the level which I wanted to tell you, MRI of the intracranial circulation. This is the right internal carotid, left internal carotid dividing into right MCA, left MCA, and right anterior cerebral and left anterior cerebral. This is the anterior circulation. This is the posterior circulation formed by the right vertebral, left vertebral forming basilar artery dividing into right posterior cerebral, left posterior cerebral arteries. Okay, this is the surface shaded display of intracerebral vascular anatomy. CT angiography is showing the vascular anatomy of the circle of Willis. Now, when you are aware of the normal anatomy, this is the normal anatomy. When you are aware of it, anything abnormal you can pick. Now, look, can you appreciate anything abnormal? Everything is thin and going on. Now, look at the tip of the basilar artery. There is something globular. So this is an aneurysm of the basilar tip. Okay. This is the DSA, digital subtraction angiography in the lateral projection. Internal carotid injection was given through internal carotid artery, depicts the large arteriovenous malformation. Look, it is the early filling of the vein. When the arteries were filling it, there was early filling of the veins. Okay. Now, the last topic for your bird's eye view, that is interventional neuroradiology. Endovascular techniques for lumen restorations are intra-arterial thrombolysis. It is used in treatment of cerebral vasospasm. It is also used in angioplasty and stenting of extracranial and intracranial vessels, and endovascular therapy for intracranial aneurysm. So this is a growing field and it is being used as I have listed. I'll give you an example. Look at the left carotid angiogram showing severe stenosis of the M1 segment of left middle cerebral artery. If you are aware of the anatomy, if you know your anatomy, you can make it. This is the angiogram of the left carotid artery dividing into MCA and ACA, middle cerebral artery and anterior cerebral artery. You can easily make out that there is significant narrowing. Since I have shown you now the anatomy, this is the normal anatomy, you can easily see the caliber. And there is further distal tapering. But if there is interruption in the middle, then there is stenosis. Okay? Now there comes the role of the interventional neuroradiology. Angioplasty and stenting of left, this is angioplasty and stenting of left MCA stenosis was performed. Balloon is seen across the stenosis. Then post-stenting angiogram was performed and the lumen was restored and patient was rescued. Now, this is another example. Like I have shown you the aneurysm of the basilar tip. So what did they do? They coiled it. They put the coil inside. Endovascular intervention done. Coil show obliteration of this aneurysm. And further, what is most important, that they should preserve the further or distal circulation. So they have preserved the adjacent arteries. Rest, there is no other abnormality. Thank you very much. Any other question? question from Miss Sakina. She is saying, if ischemia appears isodense in the early stages of CT and MRI, how is it detected? Good question. It means that you understood, mashallah. I've told you that there are secondary signs also, that there is gray white matter loss. It is a subtle sign. There is loss of basal ganglia appearance. You cannot make the discrimination between gray and white matter. There is insular ribbon sign. There are other multiple signs. We can only tell you gross things. So the first thing is there is loss of gray white matter differentiation. Then there comes the swelling. Then there comes the mass effect. So after the loss of gray white matter differentiation, there comes the hypodensity. And the other thing is dense MCA sign. You can pick with that also. We can see yes, we can see, but we cannot confidently describe it. We can see it as a mass effect. On MRI, we can see it as a signal void, but it is confidently diagnosed, described on angiography. My pleasure. Any more questions?